and welcome to the Fertility Conversations podcast. The goal of this podcast is to create more awareness about infertility and to provide support to people trying to conceive. Thank you for listening today, and we hope you will be encouraged. And now, here is your host, Ola.
Welcome, everyone. This session is a bonus episode, which is a recording from the Zoom call that was done on October 25th, 2020. The session was the first one of its kind, and it was focused on pregnancy and infant loss awareness support session, where people got to log in and listen to our speakers and also have their questions answered. So thank you so much for listening.
So much to everyone for all the hard work that has been put in to put this together. So a round of applause to everyone. We're going to be throwing stars a lot and clapping for people just so we recognize that people are here. So thank you very much. We are going to start with our first speaker, and she is going to take us through her journey, and she has already given us a little bit, and we are going to give Natalie a chance that just to share her story for a couple of minutes, and then we will move over to the other speakers. Natalie, over to you. Thank you.
Hi guys, I've already given you kind of a flavor for our journey. So my husband and I are both from Zimbabwe, I'm half Zimbabwean, half South African. My husband is Zimbabwean and from an African background living in the UK. When we got married in 2008, we thought that babies would just come naturally. And being of a very strong Christian faith, we thought if we prayed enough, if we fasted enough, it would happen. It didn't happen. For 8 years, nothing happened. And we eventually decided to go and start seeking medical treatment. And it took me the longest time to convince myself as a woman of faith that seeking medical treatment was not betraying my trust in God. And I remember going for the tests, and I think initially with the NHS, they just rebuffed everything. Their initial thing was like, just go back and try again. It was constantly go back and try again. But I remember knowing in the pit of my stomach that there was something else that needed doing. And I remember thinking I need to just seek more help. Eventually, we ended up going privately for our IVF cycles. But when we went into this, there was just very little information available. We didn't know where to start. We had very little information. We honestly just thought IVF was going to be a silver bullet. And I remember going into this thinking we will do this only once. Boy, were we mistaken, because we ended up doing 12 IVF cycles because it turned out that there were immunology issues. There were some male factor issues as well. So it unraveled, and we ended up going to a clinic in the Czech Republic who were just amazing and saw us along the way and helped us every step of the way. They were absolutely brilliant, very supportive. Unfortunately, through all our cycles, we had 7 losses, and we didn't understand why it was happening. It led us to end up reading medical journals and doing research ourselves. And through all this searching, we ended up with this master spreadsheet, because my husband is of a financial background and statistics are very important to him, because he's like, okay, we're almost getting there, but we need to record our journeys. And from that birthed an app, which we've launched recently, which is available on Android and App Store. And the app just helps you record your journey and helps you know what how you respond to every cycle. You can put your details in there, your data in there. And I think that really helped me along the journey, is to go back and revisit it. We've recently cycled again. We did a frozen embryo transfer, and this was cycle 13. It does not get any easier. You would think after doing so many cycles, you think I've got this, but not at all. It felt like a brand new cycle. It felt like day one. The drugs were kicking me in the butt every day. It was tough. It was so tough. And I think getting that BFN, the big fat negative, was just as tough. It hit like a ton of bricks. You think you'd become accustomed to it, but you don't. And I think I'm just here to encourage, to say that, yes, you know, we got our miracle baby, we got baby Joshua. He's such a joy. But even when you cycle after having a baby, infertility is still there. You know, it doesn't go away overnight. And I think I'm so grateful for this group of women, this support system, because I remember having a miscarriage and getting up and going to work the next day and thinking, I just have to keep going. There's nobody tells you. And I remember a moment standing there and thinking, okay, I mean, I've had just about every miscarriage known, the miscarriage, the blighted ovum. I've had where the medicated miscarriage. I've had the DNC. Where I've miscarried at home, and you think, do I flush? Don't I flush? What am I supposed to do? Nobody tells you what to do. And I think especially within our communities, we don't talk enough about it. I don't know, but culturally for us, it's talked about, but in hushed conversations, or if somebody mentions it, it's like, no, we don't talk about that. And I think for me, it's important that we give women a voice, that we have a voice, and that our stories are relevant and our stories matter. And that is why I'm so passionate about it. I will always be passionate about IVF from a woman of color perspective, from a woman of faith perspective. And, and also coming to the point that failure is okay. It hurts, but it's okay. And it doesn't mean that you don't have the victory. It just means you're still in the battle. And so that's all I wanted to say, is just, I wanted to encourage you. If you want to follow me on Instagram, my handle is my_IVF_miracle. And I think I'm here to support, to learn, because even though I've done so many cycles, I'm still here to learn. There's always so much to learn. Thank you.
Thank you so much, Natalie. That is very encouraging from you. And I'd like to point out just a couple of things that you said. One, being that we don't talk about pregnancy losses. It's something that is hushed about. We shouldn't talk about it, and it leaves certain scars in us that we couldn't grieve properly. Because everyone just wants to rush you into forgetting that you were pregnant, as if that itself is going to bring healing. So thank you so much for all the work that you are doing. It's much appreciated. We are next going to move on to our infertility counselor and coach, and I am going to introduce to us Kezia Okafo, who is an infertility coach and counselor. She provides specialist emotional support on your fertility journey, and she helps you with less stress and more able to cope with events and treatments that you have to endure. Because I would, think that a lot of patients that go through IVF, they are really not prepared emotionally and otherwise, especially if it's the first time that they are going through it. So this is why a fertility coach comes in, and the fertility coach will then assist you in what to expect. She is an author of a newly released book, Flipping the Script of Infertility, and it is available on Amazon. We will post her website on all of the organization's stories. I think even the next coming speakers, we will post their details on all our stories. So if you would like to find out where you can get hold of them, tomorrow or today later on, you can get details of all our speakers from all the organization stories. So ladies and gentlemen that are here, help me welcome Kezia. Kezia, all over to you.
Thank you. Hello, everyone. Nice to see you all here, and so many faces. It's really incredible. So thank you for having me today. As I was introduced, my name is Kezia, and I am a infertility counsellor and a fertility coach. and also just released a book called Flipping the Script on Infertility. I think it's really important. I can just wait. Sorry. Yeah. So what I really do is I help women to deal with the emotional distress around infertility and the mental health aspect, because I think through my own journey of infertility, that was the thing that I found was missing, that people just weren't talking about enough. And during my training, I was able to connect the two, but I don't think it's always obvious to women going through infertility, and that's whether they're going through IVF or trying on their own. And I think you're right, you know, people go into IVF not really knowing what to expect, but I think there's also this kind of misunderstanding that actually you don't just walk into IVF, you don't start trying on Monday and walk into IVF on Friday. You've already been through a infertility journey just to get to IVF. And so what toll does that already play before you've even started IVF? So for me, it's really important that women understand that, you know, everything that you're feeling around infertility and, you know, the loss of your dreams, the loss of what you thought was going to happen in your life is important. And we need to acknowledge that and recognise that. So I'm here today anyway to talk about miscarriage and pregnancy loss and the effect that it has on us as women, but also on our relationships and on our family. And what I found with the women that I work with is that there's really, women get told, well, this happens, 1 in 4 pregnancies are lost, and as if that's some comfort. And the women I meet are not comforted by that, because you didn't lose 1 in 4 babies, you lost your baby. And that had a meaning and a significance. And so I just feel like we need to understand that more, and we need to be talking about that more, because the more that we talk about it, the more that we share these stories, the more that we don't feel so isolated and alone. So the impact is huge, especially to a woman, because obviously it happens to her. But I think we also have to be mindful of the experiences of those that witness it, so partners or friends or people that go along with you or support you through it, because it is a really, and for some women that I meet, it can be an extremely traumatic experience. And again, that's another thing that isn't talked about, that actually a miscarriage isn't just something that happens. Actually, it can be extremely traumatic. And just listening to Natalie's story, which, you know, you so gracefully shared, and I think we're all very thankful for, is that it is traumatic. You know, it doesn't matter how many you go through, it doesn't matter the circumstances, you know, it is a really difficult experience and it's distressing. And so to be given a simple leaflet at the end of it, as if that's comforting, is not comforting. So I'm really quite impassioned about this topic, because I think the medical community hasn't caught up with their empathy and their compassion around this. And usually women are, you know, who are experiencing miscarriages are put on, you know, pregnancy wards with women that have babies. I mean, there's so much stuff around this that I think we're just not helping women go through these experiences. So, and it's beyond the impact of the lost dreams and hope shattered, but there's also a loss of confidence in herself. You know, we're told that this is natural, we should be able to do this. This is what our bodies are made for. But, you know, this is what we're here for. Our woman's purpose or a woman's job is to have children. And so when she experiences a loss, she's lost confidence in herself too. Like, why can my body not do this? You know, what's wrong with me? So there's all of this going on. This isn't what my life was meant to go like. Now I got married, I'd done everything in the right order, got married, and now I'm meant to have children. And that's not, why is this not happening in the way I thought? So there's lots of, it's so deep And I think we have a complete misunderstanding, whether it's in infertility or miscarriage and baby loss, of just kind of trivializing it, of kind of just going, well, get on with it, you know, keep going. And I'm like, you know, in my job, not just through my own experiences of going through infertility, but for the women that I work with, I'm just astounded by their stories every single day. And they always say to me, why am I not over this? And I'm like, well, you're not over it because it's not that simple. There's a process, there's a grieving. You're having a natural reaction to a traumatic and stressful experience. And we don't talk about it enough. And I think that's really damaging. So why I'm thankful to be here today talking to you, and why I'm thankful for groups like this that we're having these conversations, because I think it's really important. So when it comes to miscarriage, one of the things I think we have a tendency to say to women, get on with it, like, go on, just try again, at least you know you can get pregnant. Don't think that's really helpful. I think actually what we're dealing with is loss and grief. And we tend to, you know, when we have death in our society, we have loads of ways of dealing with that. We have rituals around, you know, burials and wakes and, I don't know, you know, celebrations, life celebrations. But when a baby is lost, when a miscarriage is lost, when an embryo, you know, if we really go into this, even when an embryo is lost after a failed cycle, what we're really dealing with is grief. And so grief in any other way, in any other form in society, we would, you know, rally around someone. So I don't think it's as easy as saying, women, let's get on with this, let's just try again. I think actually it's making space to grieve. And of course, men and women deal with grief in very different ways and deal with stressful and traumatic experiences in different ways. Women need to talk. We get a lot out of talking. And when we talk, we process what we've been through and we process our experience. And so it can become a very healing thing to talk about. But when we're around other people who don't understand and then can't talk to us about it, it can feel very abandoning and isolating. And then when we're with our partners who helplessly are dealing with it in their own way, but men deal with stress and trauma in very different ways. They want to do something. So they want to go out and play on their video game, or, I don't know, go and bang something, go to the gym and work it out. They don't want to talk about it because for them, talking is like, they're just not evolutionary programmed to talk in that way. They are the go out and provide and do things. So men and women are dealing with it different ways. And so with men, I'm always encouraging men to just listen. We don't have to fix anything. And I think that's what a lot of people try to do when they're talking to someone going through grief or loss, is that they want to fix it. So we tend to get people saying things like, it's okay, it'll be okay, you'll be fine. And what we find is that we get shut down because in their discomfort with our sadness or our anger or whatever it is we're feeling, they have to manage that. And so they just go, oh, it'll be okay, you'll be fine. And so what I always encourage people to do is just to listen. We don't have to fix anything here. But for the woman, it's going to be very healing to be heard, to be seen, and to be listened to. And it's really important that we give space for that in the grieving process. The other thing I would say is it's so complex, you know. Dealing with grief, dealing with loss is very complex. There is no linear timeline to it. It's like you don't experience it and then you kind of cry for a week, get angry for another week, cry again for another week, and then you're done. It's not like that. There's no linear time. it can come in waves. I always like to think of it as in, you know, when you've got the tide, sometimes the tide comes in and it washes over you and you can cope with that one. And then another time a big wave comes and it's much bigger and you feel like you're going to drown, but it goes out again. And then you might get another wave that comes, but this one's a little bit more bearable. And it's just a constant ebbing and flowing of feelings. And eventually things pass, but there's no time or structure of how anyone is meant to go through it. So there's no expectation of time when it comes to healing and grief and loss. But there's also no expectation on exactly how that should look like. So it's going to look different for every single person that experiences it. There's no one way, there's no right way, there's no wrong way. But I think, again, we need to make space for that and allow that. And I don't think there is much allowing in our society. And maybe that might change. I hope it will change the more we have these conversations. And that kind of leads me on to the importance of creating rituals around miscarriage and loss. So I work with women, and when we were working face to face before COVID, we would actually create little ceremonies. So we would light a candle, we would sit there and we would talk about what happened. I would ask her if she wanted to say some words to her child, if she knew what it was, a boy or a girl, if she had a name, you know, when was the due date. These things are really important because she doesn't forget these things. She doesn't forget the date of the loss, but she also doesn't forget the date of when she was meant to give birth. And so we just talk about it and we honour it, because I think a lot of women, when they go through this, experience it as people don't want to talk about it. People don't want me to talk about it. And so what she feels like is like, I must silence myself, I must keep this all in. And maybe I should just, you know, forget about it. But that's not helpful to her. It's really not helpful to her because she hasn't forgotten about it and she can't forget about it. So when I work with women, we honour that. We talk about it. We talk about not just what happened and the trauma, but, you know, the name. The name is important if she had one. The due date, everything around it, if she had bought anything. And so now I encourage women to do that with their partners. You know, if you've got a garden, go and plant a tree or your favourite flower. If you don't have that, maybe there's a painting or a picture that you have. Light a candle with you and your partner and just, I don't know, whatever comes to mind, you know, speak what is on your heart. There are so many different ways and each way is really personal. But I really encourage women to do this because I think there's an importance about not dismissing your experience, but really honouring the pregnancy and that baby, that life, you know, and all that you expected from that life. Because you did, you know, the moment that you got your positive, you had ideas about what that would look like, what that baby might look like, what its life might be like, what your life was going to be like. So you really need to honour that. And so I think rituals are a really important part of the process, because I think forgetting and moving on is quite damaging. You know, that idea of just get pregnant again. And when we get pregnant again, all we do is build the anxiety and the fear of, well, what if I lose it again? And as we all know, pregnancy, even just, you know, getting your pregnancy positive test is a really anxious time. It's joy, but it's loaded with anxiety. Like, you know, what's going to happen? You know, 9 months is a long time. So, and that's, you know, just a normal response. But when you've had an experience losses and you take that into every pregnancy, well, the fear and the anxiety is almost tripled, if not more. So again, it's like we need to really look at that healing process first before we think about going on and having other pregnancies, because the more we can heal, the less inclined, and the brain does this automatically. We take a past experience because the brain wants to know what's going to happen. It's its way of protecting us and preparing us for what's to come. And so it will take a past experience and it will project it onto the future. So every pregnancy we have in the future, you're going, well, what if? Because last time when I got to X amount of weeks, that happened. Last time I started to spot or whatever it was at this time. Last time I went to my scan, it wasn't good. So we're already preparing for those things. And so that's why I think the healing process, the grieving process, whichever way we do it, is really important so that we can say, okay, that happened and I make my peace with that. And now I can look forward to, you know, life and what it could be. Not to say there won't be any anxiety, there always will be, but we can manage that, you know, without it being unencumbered by our past experiences. So I think that's really, really important to say that. Another thing I think is other people, and I would say this with caution, but I think other people, when they are, and I kind of touched on this a little bit earlier, when they don't know what to do with our hurt and our pain, they go to reassurance. And so I never think I don't think people are deliberately insensitive or deliberately trying to be hurtful. And I think that's always, if you can be mindful of that when you are in receipt of a hurtful or insensitive comment, it can really help you to know that it's not personal. They're not trying to deliberately cause me pain. But I think people will say insensitive things all the time. And the important thing is to know we can't control that, but we can say, we do have a right to say, I don't want to talk to you about this. And that's a boundary. It's just saying, I can't talk about this right now. It's too painful. I just don't want to have a conversation around this. And it might not be those words, you might find different words to use, but I think it's the importance of knowing that you can say, no, I don't want to have this conversation. In fact, you're not the right person for me to have this conversation with. And so it's about finding the right people, the right support to talk to. And then when we are confronted with people who we just know are not going to get it, are not going to be understanding, who aren't very empathetic, we can just say to them, actually, can we talk about something else? And that's okay. I don't have to justify it. I don't have to give lots of reasons, but I do have to know that I am adult enough to make that decision and to be able to communicate with that person, actually, this is a no-go area. Which can be difficult, especially with family. And it might have to be like boundaries of steel. You know, I've got some family members where I'm like, okay, yeah, I've got to prepare myself for this. You know, there's always someone, but I think the more that you know who those people are and how you're going to have to prepare yourself for that, the more you can have those conversations. I don't always think avoidance is a great way, but sometimes if that's the only way to deal with certain people, then do that. It's whatever works for you and whatever you can manage with. So that's what so that's people. We can't control others. We can't control what they're going to do, but we do have a right to say no, or please back off, or whatever it is that the words are. So getting the right support is all about being discerning with who do we think in our lives are going to be the ones who are going to be supportive in the way that we need it. And sometimes support is about, I just want you to listen. I don't want you to say anything. Or I just need you to run me a bath. Just need you to make me a cup of tea. You know, it's not always, I need you to sit down and I need to talk about it and go over it. But it's really like, or I just need to have some space. I don't want to talk to you today. You know, whatever it is, but it's being able to ask for what it is that we need. And it's really important. There's lots of ways to get support. There are lots of counsellors out there. And especially, I think it's very important to seek professional support when you've had a traumatic loss. When you experience, and I just want to say that traumatic doesn't necessarily mean that it was like chaos and like a big car accident and, you know, there was just like chaos everywhere. Traumatic isn't about what happens. Traumatic is about how we feel about what happens to us. So some people might go through something and say, that's not traumatic. I would have dealt with that okay. Well, that's okay. And other people go through the same thing and feel traumatized. And it might be that you didn't know what was going on. None of the nurses were talking to you. That can be traumatic. It could be you was alone and you didn't know what to do. You know, traumatic is just whatever you feel about your experience. And if you find that actually, you know, you've lost your appetite or you're not sleeping very well, or you're having intrusive thoughts or, you know, recurring thoughts about it, then you do need to go and seek help and professional help. And it's really important that you do that. The worst thing we could do is isolate and to not talk about it. So I really encourage all women to, you know who it is that you're talking to, know that who it is that is going to give you the support that you actually need. If you don't have anyone, then do go and seek, you know, someone, you know, a counsellor, a therapist. Don't go and just kind of silence yourself and struggle on. Like for me, it's just, there's too much silence around this whole journey. It's just way too much, and we need to stop that. We need to start talking and talk more. So I can't implore you enough to go and speak to someone. And again, I mean, Natalie's story of, like, you know, going to work the next day because you feel like you had to. I think that's a lot of women's experience, especially Black women, because we are told we're strong Black women, right? You know, we get up, we get on, we carry on. And sometimes I think that is the wrong message. And everyone's different, and we all deal with grief in different ways. You know, some people want to go and work because it's a distraction, but I think it's being mindful of, you know, are we consciously distracting ourselves, or are we doing it because we just don't know any other way to cope? Very different things. You know, consciously is like, I'm going to make a choice now to go and watch Netflix because I just can't deal with the day. That's a choice. I'm consciously doing that. But if I'm constantly on Netflix because I just can't deal with my life, it's no longer a choice. I'm now in a maladaptive coping mechanism. It's not really helping me. So I think it's really being aware of, what is it I need? Do I need time off? Can I ask for that? Can I go to my doctor and get time off? Or do I need work because actually I just want to keep going and keep going? And then making sure I've got the support around me, that if I go to work, when I'm outside of work, or, you know, or even if, you know, talking to managers or whatever at work, I have the support that I need. So I think there are lots of different things that can help. And this is really my final point. But my biggest thing that I want to say is, there is such a rush in our society to get back to normal, to get back to life, to get back to just carrying on like things don't happen and life doesn't happen. And so my biggest point is just saying to women, no matter your experience through this journey, take your time. If you need time to, you know, be on your own, or you need to miss a cycle, or, you know, you need to take a break, or whatever it is, you know, give yourself time, and give yourself time to heal. You know, there is, I know that we are pressurized by aging and this fear that we're just getting too old, but I think the stress of that isn't helping us to conceive any quicker, or to have healthy pregnancies, or to have healthy lifestyles. So please take time. Take as much time as you need. Give yourselves that gift. I do really believe that's a gift. And there's ways you can do that, you know, even if it's just giving yourself time to go for a walk, or time to sit on your own and journal, or taking time off work. We can do it in a number of ways, but know that you're worthy of that. Know that you deserve that, you know. The next one is just to feel your feelings. A lot of the time, we don't allow ourselves to feel what we feel. What we tend to do is say, I shouldn't be feeling this way. I don't know why I'm feeling this way. I don't know why I'm not over this yet. I don't know why I'm still sad, or whatever. So we make judgments about the way we feel. We make judgments about the way we should be feeling, or shouldn't be feeling. And I just say, just feel your feelings no matter what, you know, sadness, anger, frustration, whatever it is, feel it. Because the more that we try not to feel it, the more our feelings want to be felt. Emotions for me are just communicating, you know, what's happened in our lives. And the more that we can sit with it and say, yeah, I am sad today. I am really sad. Actually, it's really, yeah, I'm really feeling it today. Just acknowledge it. And we can do that again in lots of ways. But I call it tuning in, really paying attention to actually what is it I'm feeling today, and therefore what is it do I need. So if I'm really sad, maybe I need a hug. Who can I ask for a hug? Or maybe I just need a really big piece of cake. I don't know about you, but I love cake. So, you know, it's just like there's no judgment there. It's like, this is what I'm feeling, and this is what I need. And again, I think the other thing that can help, and I talked about before, was just the rituals. You know, you know, it's not silly. It's not unimportant. I think it's really important to mark your experiences and to honour, you know, your life and the life that you carried. So those are my tips for how you can really support yourself through your experience of infertility and pregnancy, miscarriage, and loss. I hope that helps. Thank you.
Thank you so much, Kezia. We really appreciate all the info that you have shared with us. One thing that you said that I have experienced in my own personal journey is when you said the idea of moving on too quickly is quite damaging, you know, because you never give yourself time to feel what you need to feel, you know. I remember I had most of my miscarriages around the month of October, between September and October. I think it's only two that happened, one in Feb and the other one was in June. And I remember last year, around October, I started having a funny period. And I swear, I was convinced that I was losing another pregnancy. When I went to see the doctor in casualty, I said, I've got a history of recurring pregnancy losses. And I promise you, with the way I'm feeling right now, I can tell you that I'm having another one. And that wasn't true, you know. They found that probably I was just having a painful period that was out of the ordinary. But it's exactly not dealing with the pain of the previous losses, that creates anxiety whenever I feel in a certain way, whenever we do happen to fall pregnant. The first default thought is, how long is this going to stay? Can the doctor prevent it? Is there anything that I did that could have caused the pregnancy loss? One of the confusions that we had as a couple, because men are also very much involved in the process. They might not talk as much. They might not be the ones that go to hospital, but the emotional toll that it takes on them, it's just as much as women go through, First of all, I was told that, I'm having recurring miscarriages because of an immunological disorder, hence that. But then no one in my family has ever had. I didn't even know what was happening to me when I was admitted in hospital. And I remember I only found out after surgery that doctor removed my tube. And that on its own was just trauma. I thought maybe they cut the tube on the side somehow, they remove whatever, and then they stitch it back together. Then my chances of falling pregnant don't decrease in any way. So it's important for us to get the right information so that we align our thoughts and expectations to the real thing instead of misconceptions and blaming each other as a couple and blaming the doctor. And we've got a doctor who's going to speak to us right now. And the reason why we invited a doctor in was mainly to understand. Most of us ask ourselves this question: is there anything that I could have done to prevent the pregnancy loss? Did I carry anything that was too heavy? Did I sleep on the wrong side? To a point where you think, am I an unforgiving person? So God is punishing me for that. Did I do something to hurt someone? Maybe this is why, my seed is not growing to a point I can give birth, So we've got Dr. Q, my very dear sister, a sister in the Lord as well. So Dr. Qinisile Diale is an obstetrician, gynecologist, and also a fertility specialist at Family Matters Fertility Center, situated in Centurion in Pretoria. She's been practicing daily the art of women's health and facing its challenges with triumph. She assists women through their trials of pregnancy, through their pregnancy journey, and all the way to a safe delivery. She is blessed with 4 wonderful children and many others that she cares for in the community. Ladies and a few gentlemen that are here, let us all welcome Dr. Qinisile Diale. Dr. Q, over to you.
Good afternoon, ladies and gentlemen, and I'm glad to say gentlemen, all the men that are involved. I always say, it really takes 2 to tango. This is a journey where it does really take 2 in this wonderful discussion, in this forum. We are really excited to be part of this forum. So I don't know if you'd like me to straight away answer questions or just discuss miscarriages and pregnancy losses as an overview. It's my field, so I can go on nonstop.
Yeah. By the way, you are a very good teacher. You've got that gift of explaining things in a way that a layman can understand. So you can start with the overview, and then we will move on to the questions later on.
Okay. So speaking in medical terms, maybe firstly I can just make us all aware what a miscarriage is. And I must say, hello, four-legged baby. So I must say that miscarriages are defined differently in different states, hey? And in certain countries, it depends on the advancement of medical technology, and therefore determining whether they can save that baby, a baby that small or not. So in our country, which is South Africa, we term miscarriage as, especially this is now in the private sector of South Africa, it is a loss that is less than 24 weeks. So any baby that is above 500 gram, 24 weeks or 500 gram, any baby that is above that at least has a chance of survival. And this is mainly in the private sector. And then unfortunately in the very same country, but in the government sector, you find that a miscarriage is a pregnancy that is less than 28 weeks, which means a 1 kg baby and below in the private sector has a lower chance of survival. Not that it cannot survive at all, but you find that there's a deficiency of staff maybe, or deficiency of ICU ventilators and all those things. So all the advancement of drugs and technology determines how the survival rate is. So having spoken about that, and also having discussed how the first thing, in my office, I sit with a box of tissues. And unfortunately, miscarriages, as much as my work is filled with so much joy and excitement, it also comes with being the bearer of the bad news, and it also, puts a lot of strain on me personally, and I know with my other colleagues as well. It puts a lot of strain and also drain on us to be the person that actually has to disclose that unfortunately there is no heartbeat. It may be that the woman is expecting that she's already 8 weeks pregnant. We're gonna pick up or detect the heartbeat, or maybe we're gonna tell her how far pregnant she is, but we have to tell her that a pregnancy never formed. Or it's a pregnancy that has been going on already, and somewhere in the first or second trimester, the pregnancy is lost. So now the first question that the woman really asks herself is, what did I do wrong? And it's a very difficult question to answer. And most times there really is no answer to that. And actually, if ever we had to answer, most times I do say that you did nothing wrong. You actually did nothing wrong, and it is not your fault, and it is not your partner's fault, So some of the things that maybe I can discuss, which are things that can affect a pregnancy that we can do something about, either to avoid or to change with the next pregnancy, things like habits that women are involved in. There are some women who smoke, and these days they'll tell you, I don't smoke cigarettes, I smoke hubbly, or I vape, or I this, I that. There are some women who still have the use of alcohol, and it's excessive use of alcohol that actually does have, alcohol affects every cell in the body, and it has a negative effect on the whole body. And that is excessive use of alcohol. and also excessive use of caffeine. So these are the habits that maybe one can look into and start with reducing. So that is something that maybe a woman can do something about, something that is within your control, the habits that one is practicing. And others that may not be in your control, but that when we do test and we are able to pick up and we can do something about, treat or manage, are hormonal abnormalities like having thyroid problems. A low acting thyroid or a hyperacting thyroid is actually disturbing the homeostasis or the normal functioning of the body. And that actually affects the pregnancy itself. So we can check for hormones like thyroid. We can check for also hormonal conditions like diabetes. Diabetes is also not good in pregnancy. So at times you find that a woman had undiagnosed diabetes, and then that caused a pregnancy loss either very early in the pregnancy, and sometimes, you know, it's one of the saddest causes of stillbirths, you know, and it's very common in terms of stillbirths where pregnancy is already in third trimester and you're coming for a general checkup and there is absolutely no heartbeat, only to find during investigations that it was actually undiagnosed diabetes, high blood sugar levels. And this can be either pre-existing before the pregnancy or something that develops during the pregnancy, of which we usually recommend that it be checked by 24 weeks of pregnancy. That's where the pregnancy has an effect on the hormones and the fetus itself. Other things that we can actually check for, which really are not the woman's fault and can mostly be detected after a history. Women are not straight away tested for all these things to say, let me check if you have an autoimmune disease or this disease, you know, straight away, because these things are very costly. I had a patient that came to me some years ago, and she came to me because her doctor was away and I was the one available gynae, and she said she's expecting herself to be 9 weeks pregnant, and now she started seeing brownish discharge. She just wanted me to check. Unfortunately, I had to diagnose her with a miscarriage, only to learn that this was her fourth one, the first time that I saw her. And then I recommended that we do these investigations for autoimmune diseases, but mostly antiphospholipid syndrome. And you know that she was unfortunately declined by her medical aid. And the tests were actually so expensive that she felt herself, and she told me, Doc, I can't afford. I said, okay, in your next pregnancy, come early then. The moment you know or you suspect a pregnancy, come through. Let's do a blood test because I don't expect to see much on Sona. And then I can maybe put you on some medication. And she came through, said, Doc, this is it. We quickly did a pregnancy test. It was positive. I said, come to my office the next day. By the time she came, we were expecting her to be about 6 weeks. But unfortunately, already it was a miscarriage. You know, until I had to say, look, the treatment for this condition is so expensive itself that I need to motivate with scientific basis for me to say, take this medication. In South Africa, it costs plus minus 3,000 Rand a month. So for you to spend that much on something that has not even been diagnosed, you're just suspecting, it's very difficult. So probably the test as well cost just under that amount. And she ended up going for the test, and we confirmed that yes, she really does have antiphospholipid syndrome with this history of multiple first trimester pregnancy losses. And this blood test that now confirmed this, she had never had any blood clotting to the lung or wherever else in the body. But with this history and the blood test, we were able to motivate to her medical aid, and really they approved the drugs, and she had to inject herself on a daily basis. Took the pregnancy all the way to 38 weeks, and she delivered a healthy baby girl. And it was our success story, you know? So thank you, yes. So these are one of the things that really, it's something that you cannot do anything about. It's not your fault. It's something that is dealt upon you, but with proper investigations and going to the depth of the causes and looking at the differentials, we can detect it and we can treat and we can get a good success story. So that is antiphospholipid, where the body has antibodies that fight the growing pregnancy. And once we detect that, the body causes blood clots at the level of the placenta. Now the placenta is feeding baby blood, which is nutrition and oxygen for the baby to survive. Now your body goes and forms clots in the placenta. It's like blocking a bridge. And now there's no more blood supply to the baby. Then the baby then ends up not having the nutrition, not having any oxygen, and demises on the inside. So what we do is just give medication, which we call anticoagulants, which means anti-clotting, preventing your blood from clotting, and then the bridge can be open, the flow can be continuous throughout the pregnancy. Other things that really women don't have anything to do with, but unfortunately dealt with this as well, is abnormalities in the womb. These can be on the inside of the womb, and you can only unfortunately detect it after going through the miscarriage, and we have the history. Then we go deeper into the investigations. And this abnormality in the womb could be things like a uterine septum, which is just instead of the womb going round and sitting like this at the top, you find that there is a growth into the womb, almost dividing it on the inside. And this now causes reduced blood supply, this area here. And it causes reduced blood supply. If the baby implants in this area, there is just no muscle wall going through it to feed the baby blood. So what we do is we go in vaginally with a camera and we cut this out. So instead of the womb sitting like this is cut out and it opens up, making more space in the pregnancy so that with the next pregnancy, implantation can take place in the right place. So this is what the uterine septum is called, and it's a surgical intervention. We firstly investigate surgically without making a cut on the abdomen, but going through vaginally. So some women are born with uterine septums. Not all uterine septums lead to miscarriages, but some women do experience miscarriages if the septum is extended. Another anatomy, abnormal anatomy in the womb would be things like fibroids. You know, I've had a lot of patients presenting with fibroids. Another story maybe that I can share with you is of another patient of mine who presented with, I've been treating her sister and we delivered her younger sister. And then she came also in early pregnancy. And when we did the Sona, unfortunately, it was a miscarriage, I think around 7 weeks. And I told her, it looks like your womb has a lot of fibroids, and I don't think your baby is getting enough blood supply to be sustained in the womb. And unfortunately, for treating fibroids, we don't recommend going through things that can affect the lining of the womb and the muscle and the ovaries. So we recommend a surgical removal of the fibroids, of which then the lady was unhappy with that, and we decided to go ahead, and she came back for the next pregnancy the following year, and it was another miscarriage. Like, I saw her almost 2 to 3 times with the pregnancy. The first visit that she comes, already there is no fetal heart, until I managed to convince her that we surgically removed the fibroids, and we went through an operation. It was successful. I removed multiple fibroids from the womb. I was happy, went inside, made sure the cavity was fine, then removed the fibroids, which are abnormal muscle growth on the muscle of the womb, and they were removed. And these now are like trying to plant a seed in a rocky ground. So, you know, if you want to go into a garden and you want to plant, you need to work the soil first and make sure that all the rocks are removed and you remove the weed and all that. So now fibroids are like those rocks in your garden, are like those rocks. And now if you want to plant and the roots need to go deep, which is the blood supply and the placenta, you find that there is no proper communication and the roots are so shallow, the pregnancy washes away. So that is the effect of fibroids in a woman's womb. So this lady as well, we removed the fibroids a couple of months later, if not the following year. She came in and she said, Dr. Q, I can tell my body is at it again. I was pregnant. The symptoms are going away. I've lost this one again. I'm like, okay, let's just do a sauna and see. And we did a sauna, and to my real impression really, and my excitement, you know, with pride, we just put that probe and we get that heartbeat and you put the volume on loud and you can almost dance to it, you know, like, hey, there's a heartbeat. And to her shock as well, she was surprised. We carried that pregnancy all the way to 39 weeks, and she delivered a healthy baby girl, and she had a boy in the previous pregnancy. It was excitement galore. So it really went to show that these fibroids were actually affecting every pregnancy that she had. So those are some of the abnormalities that you can have in the womb, in the muscle of the womb. Then again, there are other ladies who specifically have miscarriages in their second trimester of pregnancy. And they have a typical history of a painless miscarriage where they just either feel a heaviness in the vagina, and then there's a blob and a pregnancy actually falls out, or there is a rupture of the membranes and they see water gushing through. And this is a pregnancy that is already between 13 to 27 weeks, you know, and then the baby is delivered. So this is what we call cervical incompetence or cervical weakness, where the mouth of the womb is not strong enough to hold the pregnancy. And these are the ones that we actually intervene by putting a stitch on them. But again, it comes with that typical history. So it's not something that with the first occurrence, you are pregnant and then we say, let's go put a stitch on everybody. Unfortunately, it does come with a history. And unfortunately, women go through the experience first before we intervene. And other causes as well that we can do something about are infections. So these are infections which we call torch infections. And fortunately, these are not recurring infections. Things like syphilis, toxoplasmosis, and rubella and others. These we can treat, and then you can go through safely with the pregnancy. Now, things that, again, that we cannot do anything about really, that are associated with miscarriages, and we just have to soldier on with, and not meaning to discourage any woman, is things like your age. We cannot change a woman's age. You know, and the more we try to fall pregnant, we are older than the previous pregnancy. That is almost inevitable. We cannot stay the same age. So studies have shown that women above the ages of 35, and even men also above the age of 40, have got higher chances of actually going through miscarriages, or risks of going through miscarriages. And this is simply because we as women are born with our eggs. So the pool of eggs is actually even older than us, because when we start counting our age, we start at birth, but the eggs are already made with us in our mother's womb, and they keep reducing over the years, and the number reduces. So if we are 35 years old, then the eggs or the oocytes are also 35 years old, or 35 years plus 9 months, even older than us. So now with age, you find that the eggs do not have the mechanism of dividing well when it comes to fetal growth. and you find that there's a higher risk of having what we call chromosomal abnormalities or DNA abnormalities. So that is found in women that are older than 35 and men that are older than 40. But then again, you keep trying. I just usually say to my patients, it's like a factory fault. If Nike comes up with a garment or a shoe that has not been made correctly, they don't say we're quitting the factory, we're closing down shop, you know, everything is wrong. No, they put that one aside and they continue with the manufacturing until we get it right. So that is what usually happens with age and DNA abnormalities. And it is found that when women have 3 or more miscarriages, then unfortunately the chances of the miscarriages recurring also occurs. And then some people would like to know, is there something genetic maybe that could be associated with the miscarriages? And should we test our baby or test ourselves? And then yes, there are some chromosomal abnormalities that do cause abnormalities that do cause or are associated with miscarriages. We call them balanced translocations. And these still, you know, I tell couples, you know, testing for these abnormalities also comes at a cost. But then what do you do with the information once you have it? Because studies have shown again that even when the parents themselves have got some genetic abnormalities, they still have a 50 to 70% chance of carrying a normal pregnancy. So it is a matter of then encouraging the couple to grieve and prepare themselves for the next one. There is still about a chance of above 70% that the next pregnancy can still be normal. And also with the issue of the fetus itself, you find that there is also some genetic abnormalities with the baby. And this we do by either taking the products of conception, once we do the dilatation and curettage, or what we call manual vacuum aspiration. Once we clean the womb, we can take the products and actually test the products for any genetic abnormalities. And once these are confirmed, as sad as it is, but sometimes it comes as a relief to us, because once we detect a genetic abnormality, we know that the chances of recurrence are less. So it means that there is a high probability that the next pregnancy will most likely be normal. So just in a nutshell, those are the common causes of pregnancy losses. And I haven't mentioned things like hypertension that usually will result in either hypertension before pregnancy, hypertension that is induced by pregnancy and complicating into eclampsia or preeclampsia, where the rest of the body organs are involved. And these then can lead to either the loss of the pregnancy, and unfortunately, they even put the mother's life at risk. And there are some cases where you find that it's a loss of the pregnancy and the loss of the mother's life. And sometimes the baby can be saved by a delivery, and you find that the mother's life is lost with severe hypertension in pregnancy. So these are things that some women, if you find that you've survived preeclampsia in a previous pregnancy, it's a very important history to tell your next healthcare practitioner so that we can be able to put you on medication that reduces the chances of recurrence.
So thank you for listening. That was part 1 of the 2-part session. And the second part will be next, and you'll also get a chance to listen to the last speaker and also listen to the questions and answers section. Thank you.
Thanks for joining us this week on the Fertility Conversations podcast. If you enjoyed this podcast, please give us a 5-star rating and subscribe. Follow us on Instagram at Fertility Conversations. If there are any topics you would like to have discussed, please send an email to fertilityconversations@gmail.com. Be sure to tune in next week for our next episode. Thank you again for listening. Take care of yourself and do stay hopeful.